So in this child with an infantile hemangioma who was in cardiac failure, I used a combination of PVA and glue. We actually used, we went into several vessels, hepatic artery, phrenics, and actually with these smaller areas where there's no significant shunt, we actually took these smaller areas off with PVA and not with glue, and the areas that were shunting we took off with glue. And I must say, nowadays, actually, I try and get the glue a little bit further out off the whole phrenic artery. But what is actually quite interesting is, in hepatic hemangiomas, different to hepatic AVMs, probably just a proximal occlusion in the artery for hepatic hemangiomas will suffice, because the angiogenesis inhibitors, the medical treatment, will kick in as well, and all you want to do is to reduce the inflow to give enough time for the rest to work. Whereas with hepatic AVMs, like AVMs elsewhere, you really want to try and get to the nidus, so you need a more distal, you need to go deeper into the lesion to do the occlusion. Because many children, if you can reduce about 50 to 60% of the shunt, or around about 60%, you can make some improvement, and if you can get 70%, you'll really start to improve things, and maybe the rest of the medical management can have time to kick in and improve the baby. People have put in coils and Platzer devices into the hepatic artery, and that seems to have worked. So all the long effort you've taken to do all the detailed embolization may not be necessary at times. All you want to do is reduce the overall inflow, but check the portal vein. Check the portal vein with ultrasound Doppler first. It's easy. And then actually you may do an arterial portal, but that uses up a lot of contrast. So, but be careful, and you may need to do it. You can use coils. Just proximally blocking the artery will suffice, but what I would say is, if you are going to use coils, be very careful, because in babies it's not just actually the diameter of the vessels that's smaller, it's the length of the vessels that's shorter as well. And I had a situation putting some coils in a common hepatic artery, one baby, and I hadn't fully appreciated on this. I used an old complex helical microcoil, and I hadn't quite appreciated some of the length, and I had some of the coil dangling out into the aorta, and before I knew it, the coil was going down the leg. So actually we pressed on the leg, and we retrieved the coil from the other groin. So it puts a simple, it puts a relatively simple procedure into something quite complex and long. I am not saying that embolizations in hepatic hemangiomas are simple and easy. These babies are often in severe cardiac failure, they're on ICU, on maximum inotropic support, and it can be very, very difficult to deal with. So if we do angiography, we've got to decide on an endpoint. So we want to try and reduce shunts. You'll still see some hypervascularity. There actually is some peripheral reduction in the hypervascularity, and you won't see changes in the aortic caliber instantly. You won't see that for some time, so don't go looking for it. You'll be sitting in the angio room for probably a few weeks for the aortic caliber to come down. So what about the portovenous shunts? Well, these are very interesting, and there is debate whether we need to treat these or not, but we would treat them if, for example, we thought that they were the major source of cardiac failure, because they can shunt a lot of the splanchnic venous blood back into the right atrium. And there are various ways of tackling these. You can come down retrogradely from the hepatic vein and go out through the fistulae. This takes a long time to do. These procedures may take 5 hours sometimes, or even longer in a tiny baby that you're dealing with. I know sometimes, I personally haven't done it, but this is from another colleague of mine who actually punctured the portal vein percutaneously and abolished some of the fistulae, reducing the shunting, and this infant actually improved. But the infant improved as well because previous arterial embolization was done, not just portal vein embolization. But there is a problem sometimes coming in percutaneously. It's not without problems. Access usually isn't that difficult at all with ultrasound guidance, but in theory this would be a better method in retrogradely. But it is much more technically challenging, I can tell you. Even for the highly experienced pediatric interventionist, this is much more challenging. So this is only one case I have of, again fairly sort of hot off the press, of an infantile hemangioma, a diffuse type. So that's where the lesions completely replace the whole liver. And this is the group where the high mortality comes from excuse me, abdominal compartment syndrome, because of the massive size of the liver pressing on the IVC, causing major problems. And it used to be said that if these patients didn't respond to steroids, they needed liver transplantation in order to survive. Well, we now recognize that this group, particularly, you must check the thyroid function, because part of the cardiac failure that they sometimes have may be related to hypothyroidism. And if they're treated and they need massive doses, much larger than you or I would require if we were hypothyroid, and they respond at times. However, saying that, some still require transplantation in order to survive. This is the only case I know of which was recently with us, where this baby with this massive abdomen ventilated, with this appearance in the liver and on X-ray, and on angiography you can see these hypervascular nodules in the liver corresponding to all the nodules on the CT scan. We actually undertook embolization. Now, this baby was not in cardiac failure. The baby had abdominal compartment syndrome. And I will be very honest with you, the surgeons and the intensive care physicians came and they asked each of the interventionists in our department what we would do. They came and asked me first of all, and I said, well, the traditional teaching is that we only do embolization for hepatic hemangiomas when those infants are in cardiac failure, not for other problems related to hemangiomas. So they went to the next radiologist, and the next radiologist, there are 5 of us. And they got to the last radiologist, and he said, oh, I'll do the embolization. So the rest of us, our eyebrows raised, and we said, but why? Because this is not what we should do. So anyway, we had some discussion, and I suggested that if we were going to do the embolization, because there was abdominal compartment syndrome and there was poor portal vein perfusion, that we should do the embolization with PVA in a staged fashion. So we take off part of the right liver one day, a few days later, and then see how the baby fared after that and reach the function. Then we'd go back in and do a little bit more of the right liver, and then go back in and do some of the left liver. So a series of staged embolizations all over a period of 2 weeks. Well, to my surprise, the infant came off the ventilator, the abdominal girth went down, and the liver shrank down. So this was a big lesson for me, and I've actually shown this because the group at Children's Hospital in Boston, which proposed that classification, had never thought of actually doing embolizations. And I'm not saying that this should be the treatment of choice for a baby with an abdominal compartment syndrome due to diffuse intrahepatic hemangiomas, but it is worth thinking about. This baby did not require a liver transplantation. So what we did actually for the embolization, we actually went in coaxially. We brought, here is part of the right hepatic arteriogram. You can see these hypervascular nodules, and here they are on the arteriogram. And here, you can't really see it well, is the microcatheter coming out through the 4 French guiding catheter. And what we aimed to do was to take out and devascularize these hypervascular nodules, try and preserve the parent trunks, so that at least there may be some opportunity to get some arterial supply to normal liver parenchyma. So that's what we did on 3 occasions, and fortunately it worked. It is the only case I know of. So what about hepatic arteriovenous malformations? Well, these are rare. Most of them are related to hereditary hemorrhagic telangiectasia. The infants are all invariably in cardiac failure from day 1 of life. They have a complex vascular anatomy. There are extremely limited treatment options, and there is an extremely high mortality whether or not these infants are treated, no matter how well they are medically supported. So these infants don't really need steroids. These are a malformation. These are not vascular tumors.